Okay, now we will move on to the selected abstract. The talk is going to be given by Chiara Giannarelli, and she's going to talk about the role of chronic stress on experimental atherosclerosis. Chiara?
Thank you very much for the introduction, Venki, and good afternoon. As Venki already said, my name is Chiara Giannarelli. I work here at Sinai, and I'm going to talk about a research study that we have been doing here at Sinai in collaboration with the neuroscience department. And just to give you a little background regarding the impact of stress on cardiovascular disease, it's important to remember that cardiovascular disease are still the leading cause of mortality and hospitalization in Western country. There is a huge cost related to cardiovascular disease that we have to pay annually, and it is projected to keep increasing within the next 20 years. It's also important to remember that psychological disorders affect 1 out of 6 Americans, and there is also a huge cost for healthcare every year. Cardiovascular disease there is an association between mood disorders and in particular depression with the risk of cardiovascular disease, and the Interheart study showed that there is an increased risk for MI in patients with depression. So when we look at the mechanism, there are different mechanisms that are being proposed to explain the role of stress on cardiovascular disease. And among many, the more important that have been shown are an increased neuroendocrine dysfunction, an impact of stress on hemodynamic factors such as vasoconstriction, endothelial dysfunction. There is also an immune activation that could be responsible for increased inflammation in patients with experiencing stress. And there is a prothrombotic predisposition, which is related to the increased platelet activation and increased level of tissue factor. Of course, there is an open question regarding the fact whether depression and anxiety are merely linked, or there is a causal link that could be responsible for a direct impact of stress in cardiovascular disease. What we know for sure is that psychological stress is associated with increased presence of cardiovascular risk factors, because people with mood disorders are more prone to have an unhealthy lifestyle, they smoke more, and they are more frequently obese. Because of this evidence related to the association between mood disorders and cardiovascular disease, the American Heart Association a few years ago suggested that the routine screening and treatment for depression in patients with CAD. This statement has been highly criticized for the lack of direct evidence that these interventions can actually have an impact on the outcome in these patients. The aim of our study was to test the effect of stress on 2 important aspects related to the clinical manifestation of cardiovascular disease: plaque vulnerability and platelet reactivity. And to do that, we look at specific markers of plaque vulnerability. We look at cellular composition of plaque, focusing particularly on macrophages infiltration and vascular smooth muscle cell density. And then we look also at apoptosis, which is extremely important in the course of plaque progression and plaque destabilization. And to do that, we use traditional immunohistochemistry and also molecular imaging. We also tested for platelet aggregation, and we used serotonin as an agonist, because serotonin has been associated to both depression and anxiety, the imbalance of serotonin. However, serotonin is a weak platelet activator, and so it is generally used in combination with stronger agonists, such as ADP and epinephrine. Before going to the results and the experimental design, I would like to give you a little background regarding the model that we have been using to induce stress in mice. The experimental model is called social defeat, and it's based on the interaction of the mice that we want to test with a bigger mouse, which is a CD1 mice, a particular strain, which is bigger and is typically characterized by aggressive behavior. So every day for 10 days, the mouse is exposed to the aggressor, this lasts for 10 minutes, and then it's housed in a cage, in a hamster cage, where on one side we have the mouse, on the other one the aggressor. And there are holes, so the exposure to the aggressor is constant because the mouse can see and can smell the presence of the aggressor during the 10 days. After that, the animals are screened based on their behavior using this device where the animal is positioned either in the presence or in the absence of the aggressor. And as you can see here, there is an interaction zone that is closer to the aggressor and the corner zones. And through through an automatic video tracking system, you can actually automatically define how much time the mouse spends in the interaction zone or in the corner zones in the presence of the aggressor. And you can come out with the so-called social interaction scores, where you can differentiate the animals based on their behavior. The susceptible mice are the ones that spend more time in the corner zones, in the presence of the aggressor. The resilient mice are the ones that are spending more time in the interaction zone. And the resilient mice are characterized by an anxiety-like phenotype. The susceptible mice have a depression and anxiety phenotype. We also is usually included also a control group that it's basically mice not exposed to social defeat. So what we did, we used a cohort of ApoE knockout mice. We exposed them to social defeat, and we characterized them for being susceptible or resilient. Soon after defeat, we tested for platelet aggregation, and 6 months after, while they were kept under Western diet, we tested for apoptosis, and then we harvest the aorta and we looked at process it for further analysis. So the results that we got are as follows. So here you can see the distribution score of the animals. So we have the resilient mice over here on the top. In the middle you can see the controls that have a behavior similar to that of resilient, and the susceptible mice. And we wanted to account for potential confounding factors, so we monitored the body weight over time, and we did not see any significant difference between the groups, which is important because this could be a confounding factor on for plaque progression. We look at plaque composition, and as you can see, we observed increased macrophages infiltration in the resilient mice versus susceptible and controls. And we also saw that there was reduced vascular smooth muscle cells density in both resilient and susceptible versus controls. And when we look at the ratio between these two densities, the resilient and the susceptible show reduced ratio versus controls. And these findings suggest that these resilient mice and susceptible mice show a plaque phenotype that is more vulnerable versus controls. So given the importance of apoptosis on plaque progression and vulnerability, we used molecular imaging. So we inject radio-labeled annexing A5, and 3 hours later we performed microspect and micro-CT. Then the aorta was harvested, and we performed also ex vivo scan of the aorta and gamma counting. And the whole concept is based on the ability of annexing A5 to bind specifically with high affinity to phosphatidylserine, which is exposed on the cell surface upon apoptosis activation. So those are the results that we obtained. And as you can see, we observed decreased apoptosis in the susceptible mice versus resilient and controls. And those are the pictures that we obtained, representative pictures confirming these, that clearly show a reduced apoptosis in the aorta of susceptible mice. We wanted to look at these markers of apoptosis in the aortic specimens as well, so we performed tunnel. And as you can see, we confirmed reduced apoptosis in susceptible mice versus the other two groups. And when we looked at active caspase-3, which is a specific marker of apoptosis, we also observed reduced expression of active caspase-3 in susceptible mice. Looking at platelet reactivity, here you see the representation of the results of platelet reactivity to serotonin and epinephrine, and we observed increased platelet aggregation in resilient mice versus susceptibles and controls, while we could not observe a significant difference when the platelets were challenged with serotonin and ADP. So in summary, our data show that there is a direct effect of chronic stress on markers of plaque vulnerability, and that there is an effect also on platelet reactivity. So these observations show that the exposure and the individual response to chronic stress in this specific model, resilient versus susceptible, has a direct impact on markers of plaque vulnerability and platelet reactivity. And meaning that there is a possibility of a role of stress in promoting atherosclerotic disease, its thrombotic complication that may lead to cardiovascular events. Thank you.
All right, we open for questions. Zahi?
So I have two brief questions. Why choose the apoptosis as a marker? I mean, we know from from plaque and plaque high risk and vulnerability, there's a lot of other markers. So I just want to understand your thinking behind that.
Well, the thinking was to look at. The thinking was to the fact that we know and we have been publishing regarding apoptosis, increased apoptosis in plaques that are more vulnerable as a result of macrophages death. And we wanted to look at that marker as well. Of course, we were surprised to observe reduced apoptosis in the susceptible. This is not what we expected. But the story is not so simple, because apoptosis has been shown to have a differential effect based on the timing during plaque progression. So while it's protective early on, it can be detrimental when you have a well-established plaque. So it's a start. Of course, there are open questions. I don't have an answer. For that, it's possible that we need to look at, over the course of plaque progression, in this case 6 months or maybe longer, to look at how stress impact the apoptosis at different timing. So we wanted to look at different aspects, and I think that this opens the door for further hypotheses that we need to test.
That's great. Very quick question. The images you showed, these were ex vivo or
those
in vivo?
Were ex vivo, yes.
Okay, so question at the back. Okay, hang on.
Thank you for an excellent talk. You used a particular model for stress, that of social defeat. Do you think it makes a difference which model you use, whether you used other models of stress?
Well, yes, that's a pertinent question. There are different models to induce stress. in mice or especially in rodents, let's say. And we decided to use this model because we have here in Sinai huge experience with that, and we wanted to start with a validated model of chronic stress. So we were more interested into the chronic effect of stress rather than the acute effect of stress that might generate adrenergic response and then, as a result, impact platelet activation as a result of increase of epinephrine or norepinephrine circulating. So we decided to use this method because it's been very well characterized and validated, and we wanted to use a well-established methodology.
Right, Jan?
Yeah, my question comes along with the comment from Zahi.
Mm-hmm.
I mean, I'm really doubting that you're imaging apoptosis in those plaques with annexine. I just presented today during the poster session our results from our group in Maastricht, where we also used the mice model of atherosclerosis using annexine 5, technetium-labeled annexine 5. And we actually couldn't find a pretty low degree of apoptosis in all the plaques we examined in histology. What we indeed found was a pretty nice correlation with the phosphatidylserine receptors, but this actually comes not along with the degree of apoptosis. So one need to be aware that by using annexine, you are not usually or you're necessarily imaging apoptosis.
Yes.
That might be due to the fact that phosphatidylserine is also a marker of stress. So that's what we found, that those plaques do have an increased degree of stress, but that's actually not apoptosis at all at that point.
I agree. It's not. It has been used for imaging apoptosis, but of course we are well aware that other cells, not necessarily apoptosis, can express phosphatidylserine. So we sort of are confident regarding the results on apoptosis because of the pathological validation that we have done based on active caspase-3 data, which are pretty strong, in my opinion, especially when combined with tunnel results.
I mean, that's really surprising to me because we did a comparable study in malignant tumors before and after chemotherapy, and we could also not find any kind of apoptosis. So I mean, if even in that model with a malignant tumor where you really need to expect apoptosis after chemotherapy, you cannot image apoptosis with that type of tracer. Yeah, I'm really doubting that this is going to work in the plaque.
I don't know, I'm not aware of similar data in the plaque, but in tumors, microvasculature also express phosphatidylserine, not necessarily as a result of an intervention. So maybe there is a different microenvironment. So even though there is microvasculature in the plaques, which has been described, I don't think the mouse model is really great for that because there are really very few neovessels that you can see in the plaques. So that could be a possible explanation.
I have a comment. Without entering in the issue whether annexine detects apoptosis or not, I think that it's clear that mood disorder increases apoptosis because we have done histopathology. And one of the reasons why we focus on apoptosis, as Dr. Fayad asked before, is because the apoptotic macrophages seems to be the responsible for the release of tissue factor. But we have to forget something that's very important. The clinical complication of cardiovascular diseases is not only because you have a plaque. You need to have a ruptured plaque and an acute thrombus. So the reason going to apoptosis is because we are looking to the apoptotic macrophages as a source of metalloproteinases, as a source of tissue factor. And again, I am not going to argue with you about the imaging because I am not an expert, but certainly the pathology show us that there is apoptotic macrophages there.
All right, thank you very much, everybody. So I give Chiara her certificate. Thank you.